Hi, this is Nursing It, and today we're going to be talking about the concept of the professional nurse and how to really shape the type of nurse that you can choose to become. Ross C. Williams says, to do what nobody else will do, a way that nobody else can do, in spite of all that we go through, that is to be a nurse. And one thing that we consider a lot in nursing is the experiences that shape us, and those can be both positive and negative, and that can be from our patient encounters but also from our leaders, and we learn both from those negative and those positive experiences that help shape us into who we do and do not want to become in our own practice. The image of the RN is one of hope and goodwill, empathy and caring. We're the largest workforce in healthcare and typically spend the most time with patients, addressing their issues, documenting their history and concerns, and helping them navigate the healthcare system. And we advocate for their needs at every stage of life and health. With the needed growing diversity of the workforce and the movement away from the white uniforms of our predecessors comes a new challenge for nurses. As we seek to achieve higher degrees and be recognized as professional healthcare providers among the team, we are struggling to present a unified image of what a nurse is. Some hospitals have implemented hang tags for IDs with large RN lettering, as well as LNAs, LPNs, RNs, APRNs, PAs, MDs, DOs, etc., to identify the team. Some have created uniform requirements by department or staffing level. For example, all LNAs would wear purple, while all nurses wear black or navy, and all housekeeping staff wear gray, etc. But critical to all of this is the need to introduce yourself at every encounter and include your title to reassure patients and decrease confusion. Behind the scenes, the RN of today is working harder than ever to manage higher acuity for patients, a larger patient assignment, oversee and delegate safely to assistive personnel, and still stay on time with charting, assessments, treatments, and medication administration. The skills of time management and prioritization are more critical than ever. Procrastination is a dangerous habit in today's workplace. The RN should reflect on the shift's performance and recognize any procrastination or passive-aggressive behaviors that could endanger patient safety or outcomes and analyze the reason behind it. Often, it is as simple as not being familiar with the skill and needing assistance. Sometimes it's more complicated, such as feeling overworked or bullied, and in these cases, it's unfair to make the patient suffer for the faults of the system or staff. To become a professional RN in today's challenging workplace takes effective communication skills, conflict resolution skills, effective delegation and supervision skills, a knowledge of the legal and ethical issues related to nursing, awareness of the social and cultural needs of the patients, a willingness to participate in advancements in information technology and emergency preparedness, development in leadership and management skills, and an understanding of healthcare policy and politics. All of this starts with the ability to effectively enact change. Effective change begins with you. As an agent of change, you must be aware of the fact that where we are now is not perfect and it can never be good enough. Medicine is always changing, and therefore we must also be prepared for change. We must ask ourselves, is there a better way? And when we find one that is better than what we have now, we must become dissatisfied with our current state and want to achieve more. This might be personal, such as, how could I do better at time management or communication? And this might be professional, such as, how can we improve our throughput time or our documentation to increase reimbursement? Once you have a vision in place of what that better looks like, it's easier to enact change. Consider the resistance. What is holding you or the group back from changing? Change can be scary, even change that's planned and positive. For effective change, it is best to plan change and implement it slowly with feedback from all of the stakeholders, so you know if you need to change your plan along the way. The first steps you take to implement your change will start the ball rolling toward the goal, but you have to be able to see the finish line before you start. Have a plan in place. Why do I need to change? How will this change benefit me once it's complete? How am I going to make this change happen? Once you have a path towards your vision, put it into motion and overcome that resistance to change. Change happens when the momentum from your dissatisfaction, your vision, and your first steps are greater than the resistance to change. Nurses actively participate in research and incorporate evidence-based practice into their everyday plans of care. It's important that you understand different study designs, research methods, and the importance of evidence-based practice and research utilization. Study designs include things like quantitative and qualitative research, as well as triangulation. Quantitative research is quantifiable, meaning that there is a number or a statistical value associated with the data. While qualitative research gives you a quality or a descriptor, it's a survey where you elicit feelings, thoughts, or experiences. Research methods are varied, but include things like those surveys where we use tools to collect data from people like demographics, social characteristics, and behavioral characteristics. Experimental studies then would manipulate independent variables using treatment groups and control groups who receive a placebo to observe the outcome or effect of the independent variable. These can be used to establish a cause and effect, like a new medication or a new treatment. Meta-analysis goes back and reviews multiple research studies on a specific topic, and then the findings are statistically analyzed. This synthesizes data from multiple quantitative research studies to allow for greater confidence in generalization of the results, so that could be then extrapolated onto a larger population. For evidence-based practice and research utilization, the nurse should question their current practice. If there's something we could be doing better, back to that change, right? And then develop your PICO question. Find peer-reviewed research and evaluate the validity of that research. Collect data about your current practice and then create that plan of how you're going to change. Integrate the evidence-based practice data into your practice, so implement that change. And then eventually your evidence-based practice will become part of your plan of care. Bedside nurses have some of the greatest impact on evidence-based practice-driven changes in the workforce. The American Association of Critical Care Nurses say that nurses must be as proficient in communication skills as they are in clinical skills. And the Joint Commission says that open and candid communication with patients and their families is a key component of safe and effective health care. The nurse is responsible for communication, often maintaining effective communication between the patient and the healthcare team. Ralph Waldo Emerson said, "What you do speaks so loud that I cannot hear what you say." Our nonverbals communicate so loudly with others. It's really important that we're congruent in our actions and our words. The use of positive communication techniques is essential when interacting with patients and families. Peter Drucker says the most important thing in communication is hearing what isn't said. We need to listen. Positive communication includes developing and maintaining trust, using I messages, establishing eye contact, keeping our promises, expressing empathy, using open communication techniques, clarifying the information received, including asking about those things that aren't said, and being aware of our own body language. If you use touch therapeutically. Avoid negative communication techniques such as blocking conversations or avoiding difficult conversations. Don't make false reassurances or assurances with patients because that is not honest. Try to avoid giving conflicting messages and don't use logical fallacies. We should always try to utilize our solar active listening skills. Sit facing the client, observe an open body posture, lean forward to show that you're engaged, make eye contact, and relax. And this is true of all ages. trying to maintain a level eye contact or get down to their level if they're seated or if they're a child is really critical to making them feel less threatened or less scared. Your communication styles matter. Nurses should strive to use assertive communication styles whenever possible. This requires self-confidence and the ability to set limits on your own actions and responses. We often refer to this as staying above the bar, but really you're being accountable for yourself within that conversation. The goal of assertive communication is win-win. I matter, you matter, we both need to win. Be honest and direct while valuing and respecting the views of the people you're talking to. Listen actively and use reflective feedback. Avoid aggressive communication, which involves manipulation, guilt, hurt, and anger, and don't let that get in your way, regardless of the needs of others. So people with aggressive communication want to win no matter what, and they will hurt other people to achieve their goals. Passive or submissive people will communicate allowing others to make decisions for them to avoid conflict out of fear of retaliation or fear of that conflict. And if they win, it's just because they actually wanted what somebody else wanted and not because they got their way. Passive-aggressive communication are people who avoid direct conflict. They appear agreeable and then they undermine people by not completing the tasks, gossiping, pouting, playing the victim, or manipulating behaviors that further escalate the conflict. So these are people that you would say go behind your back or stab you in the back. During communication, keep age, gender, and cultural differences in mind. However, using active listening, those I statements, and assertive communication techniques should be the most effective in all situations. Let's be honest. While it'd be great to think that we can all be assertive and professional 100% of the time, we all have triggers that pull us below the line. The most important thing is to recognize that behavior, our own personal behavior, and stop and apologize if necessary, and then move forward in a professional manner. Self-awareness is key to improving our communication techniques. When conflict does occur, having the tools to diffuse it will make your work environment and relationships with patients, families, and the team much better. Environmental characteristics that support professional communication include empathy, equality, openness, positivity, and supportiveness. When communicating with physicians, for example, remember that you have the right and the responsibility to communicate on a level playing field with all members of the team. The same is true for the patients who are part of their healthcare decision-making team. Leadership will have different conflict resolution styles based on their conflict resolution experiences and communication abilities. Some leaders will practice avoidance, where they are passive and withdraw from the conflict, and therefore neither person is able to resolve the conflict. Some will be accommodating, where one person ends up giving in to resolve the conflict, and the other person is able then to win and to pursue their goals. This could be both positive and negative. It could be negative if you just give up because you're passive, but it could be positive if you don't have any emotional attachment to your goal and you're doing it just to kind of resolve the situation because it doesn't matter to you one way or the other. Fine, let's try your idea first, and if that doesn't work, then we'll try mine. That's accommodating. There's force or competition, where one person forces their goals to be met at the expense of the other person. That's very aggressive behavior. And then there's compromise. And compromise is not the same as collaboration. In compromising, everyone loses. Both people then give up something to achieve partial goal attainment, but nobody really wins. Ideally, we want to have collaboration and conflict resolution, where both people actively try to find a solution that will satisfy them both. This means you're both assertively communicating. It's critical to teach the steps of conflict resolution to the entire team to avoid negative behaviors during interpersonal communications. This includes those active listening skills and how to professionally respond to verbal conflict. Think about this. If everyone that you worked with knew how to determine the issue, first collect the facts before talking, and then didn't make it personal. They used I statements, they didn't take conflict personally, even if it felt like it was personal, and they talked about the issue and not people. and they always aimed to create and maintain a safe environment that was private for these conversations, that was neutral for these conversations, that felt open and safe. And they focused and refocused on the issue or the behavior rather than the individual. Think about how much more we could accomplish and achieve in resolving these misunderstandings and these conflicts and getting and moving forward with our unified goals. Conflict certainly has the potential to arrive with delegated tasks, doesn't it? The RN can legally transfer the responsibility of the performance of a task or an activity to another person, yet they retain the accountability for that task. This means that the RN retains the legal liability of the task and the care, and that can lead to conflict when the task is performed incorrectly, incompletely, or is not completed at all. And certainly it makes the nurse nervous, thinking that they are liable or that their license is at risk. To delegate safely, the RN must determine the needs of the patient and what can be delegated and when. They must be available to the delegatee, and they must assess and perform the follow-up evaluation. They also must perform any intervention or corrective action that may be required to ensure safe or effective care. Safe delegation practices include knowing the patient. So always perform your assessment prior to delegating. You should know what you can delegate and when. You should know the staff member. Be aware of their abilities and their knowledge base. Don't delegate to something to somebody who's brand new and hasn't been trained on that. Or if you've delegated something to someone before and you know that they're competent at it, then you should feel comfortable delegating that to them. Also keep in mind how many tasks have been delegated to that person and do they have time to complete the task. Know the task to be delegated. Be competent in the task that you're delegating. So if you have to evaluate the person who is doing the task or performing the task, you need to know whether or not they're doing it correctly. And if they don't have time to do it, you need to be able to jump in and do it yourself. Explain the task and the expected outcomes. Give clear information to the delegatee, and that's really critical. If you don't explain exactly what you expect from them performance-wise, do this, take this, obtain this, bring this back to me, report this, even something as simple as, while you're bathing Mr. So-and-so in room such and such today, please put on your call bell when you go to roll him or when you're ready to roll him. I'd like to come in and check his back and I'll finish the bath with you. That's very simple, but you've delegated the task of the bath to them, but you want to do the assessment on their skin while they're in there. Expect responsible action from the delegatee, so allow them to perform the task. Supervise without intervening. No one likes to be micromanaged. Assess and supervise job performance. Communicate, observe, check in, and inquire about progress or needs. Everybody likes to be supportive. Do you need anything? How are things going? Can I help you with anything? If you have downtime, it's always okay for them to delegate things back to you if they're busy. Evaluate and follow up. After the task is complete, evaluate and reassess that the expected outcomes were achieved. Errors or omissions are a learning opportunity. Take the time to support your staff to help them learn and grow, and they will know that they can trust you and will be open coming to you with questions. Proper delegation is essential to RN time management and workflow. The RN should utilize the assistive staff appropriately to create time for assessments, documentation, treatments, and medication administration. Remember that the RN can be found negligent for errors related to delegation, leading to fines and loss of license. Delegate safely and supervise effectively at all times. Legal and ethical issues will always be a concern in the healthcare field. Patients and families of patients who experience poor outcomes are often looking for a reason for the event. Many hospitals have a full disclosure policy to promote full information sharing with patients and families, giving them a full account of the error and apologizing for the mistake. This disclosure has demonstrated a decrease in lawsuits. Nursing responsibilities and day-to-day practice include ensuring the patient has consented to treatment. Informed consent means the patient has been given an explanation of the risks, benefits, and alternatives, and chooses to proceed with the procedure. This can be verbal, like for a Foley catheter or an IV, or written for something like a blood transfusion or a surgical procedure. the physician is responsible for obtaining the written informed consent, and the RN is responsible for making sure the paperwork is in the chart prior to the procedure. Implied consent occurs when the patient is unresponsive and cannot speak for themselves. In this case, the provider can assume that the patient would want what any other reasonable person of their age, gender, health, religion, etc. would want. This does not give healthcare providers the right to override advance directives or known objectives to treatment. For example, if you had a patient who was a Jehovah's Witness and refused blood while they were conscious and then went unconscious, you could not administer blood just because you thought, oh, they're now unresponsive, and it would be implied consent. It does mean, however, if you come across somebody who is unresponsive, you could perform CPR or control bleeding or manage their airway or whatever under implied consent. Torts are violations of a person's civil rights. Intentional torts are acts that can intentionally threaten or harm the physical, emotional, character, or security of a person. Assault is the threat of bodily harm. If you don't give me a urine sample, I'm going to put a Foley in you. That certainly is threatening. Battery is touching the person without consent, holding someone down to start an IV or give a medication when they have the right to refuse, taking a blood pressure of a patient who has refused vital signs, performing a pelvic exam on somebody who doesn't want it done, any of those things. Anytime you touch a patient where they're saying, no, don't touch me, that is battery. Defamation of character can be written, which is libel, or slander, which is spoken, and this is spreading gossip or untruths that damages their reputation. False imprisonment is the unlawful restraining or detaining, like refusing to discharge someone who has the right to leave or does not meet the criteria for restraint. Invasion of privacy is looking at medical records or sharing records without reason to do so. So invasion of privacy is directly a violation of HIPAA laws. Intentional infliction of emotional distress is when you show reckless disregard for the needs or rights of the patient. And this could be failure to provide empathy or emotional support, or it could be, purposeful taunting or torturing or unprofessional reckless behavior. Negligence or medical malpractice is an unintentional tort, and this occurs when there is an error made and the patient is harmed. In order to prove negligence in a court of law, 4 things must be present. There was a duty to act, meaning that you were on duty, you were being paid, and you had a responsibility to care for a patient. There was a breach of duty, and that means that you did not perform to the standard of care that another nurse in your situation with your training would have done. Harm resulted, and this means that the patient had some sort of suffering or injury. And then proximate cause. Proximate cause is that the harm was a direct result of your breach of duty. And proximate cause is the hardest to prove in a court of law. If the nurse acts appropriately with the concept of social justice, so treating all people the same, and the ethical principles in mind, it will decrease the risk of litigation. Autonomy means that the patient has the right to be involved in decision making. Nurses should always advocate for the rights of the patient. Beneficence means to do good. Do the right thing for the right reason, but because of the patient's wishes, not your own beliefs. Non-maleficence means to do no harm, or literally do not bring harm to the patient. You should weigh the risks and benefits of everything that you do. Do not administer potentially harmful treatments or medications. Do not injure others. And veracity is to tell the truth, always be honest, and use empathy when conveying difficult messages. Lastly, remember that you are only protected by your employer's liability insurance while you are being paid. Otherwise, you are covered by the Good Samaritan Act if you render care as a bystander, but do not act above basic life support levels. Having your own liability insurance as a nurse is never a bad idea. As modern medicine incorporates more complementary and alternative medicine therapies into the holistic care of patients, it's important for nurses to understand the principles of CAM and the risks and benefits of various therapies and supplements as they're incorporated in with Western medicine pharmaceuticals. Treatments such as acupuncture, Ayurveda, biofeedback, chiropractic medicine, dietary supplements and herbs, homeopathy, hypnotherapy, imagery, magnet therapy, massage, bodywork and energy therapies, meditation and progressive relaxation, naturopathy, prayer and faith, Tai Chi, and yoga have all been successfully incorporated into plans of care for patients to improve wellness, decrease pain, manage stress, and treat illness. Nurses need to be aware of their State Practice Act and the limitations of their legal practice locally. While many of these therapies have been used culturally for centuries, the licensing of nurses restricts certain practices. Certain practices like biofeedback, acupuncture, and even massage therapy cannot be practiced without a license to do so in most states. If a patient is asking for advice on taking supplements or herbs, the nurse must be cautious not to appear discouraging and to recommend that the patient speak to a physician or pharmacist to ensure there are no interactions with their current medications. Always focus on safety. Safety is critical when incorporating CAM into a current plan of care. Use therapeutic communication and advocate for the patient's needs. Information technology. Electronic health records, electronic medication administration records, biometric access devices, barcode scanning, and learning new documentation systems have created stress related to change for many nurses already working in the field. In fact, many of the experienced nurses who were at or approaching retirement age chose to leave rather than to learn these new systems. Adaptability and remaining open to change is critical for your career. As the technology industry advances, so must the healthcare industry to remain competitive and to improve communication with each other and patients. While no single EHR system exists in the United States, many healthcare systems have moved to system-wide information sharing that allows for real-time data entry by the lab, radiology, primary care, specialty offices, nurses, physicians, etc. into the patient chart. This communication decreases errors, enhances patient care and outcomes, and promotes better data capture for research and billing. Concerns do exist over confidentiality with EHR systems. However, as a whole, they are safer than paper systems. There's less chance of misplaced items, less chance of documentation in the wrong chart, and tracking of all people who access or view the records, and security systems to prevent accidental disclosure of records outside of the system. Regardless of the system used, patients have a right to know that the healthcare system is working to protect their confidentiality. One of the goals of EHRs is meaningful use. This includes 5 primary patient care goal domains. 1. Improve quality, safety, and efficiency. 2. Engage patients and families in their healthcare. 3. Improve care coordination. 4. Improve public and population health. 5. Ensure privacy and security for personal health information. Through patient portals, data collection, real-time information sharing, and system usability, these EHR systems have been a stressful change and a benefit to the patient and the healthcare system. As discussed, change is best when it is planned, implemented slowly, and input is considered as the process unfolds so that the steps can be adjusted as needed. Lewin's theory of plan change outlines the change process related to plan change. Unfreezing is the first step, and this is where the problem is identified and people are made aware that a better alternative is available. They become dissatisfied with the status quo. Moving, it occurs now that they have a vision for what could be and create a plan for how to get there. Moving includes implementing the change. So this includes like the training. Refreezing occurs when the change has become a habit or the new status quo, and people have successfully adapted to the new routine or procedure. Nurses who resist the change will fail during the refreezing stage and revert back to their prior habits. As you become a leader and are learning to inspire and promote productivity and creativity within your team, consider the type of leader you prefer to work with and the type of manager that your team needs. Transactional leaders are concerned with performance, tasks, and errors. You often only hear from them if there's a problem. They focus on day-to-day operations. Transformational leaders are interested in sharing the vision with the group, empowering each individual to accomplish goals and achieve the vision, impart meaning and challenge to work, and are admired and emulated by the staff. They provide mentoring to staff members based on need. Autocratic or authoritative management is used For new employees, this type of manager makes all decisions independently, ignoring the input of the team, and takes credit for the team's success. They give little feedback or recognition. Democratic or participatory management encourages staff participation in decision-making, including staff participation in meetings, committees, and developing new ideas or programs. This type of manager communicates effectively, builds responsibility in people, and works well with highly responsible, competent people. Laissez-faire management does not provide guidance or direction. They're unable or unwilling to make decisions. They do not provide feedback. They initiate little change and communicate by emails or memos. They may work well with professional people. As a leader and a manager, you may also be responsible for determining staffing assignments and reporting events or participating in quality and safety activities. Staffing assignments should be based on volume, acuity, layout of the unit, the skill and the knowledge of the staff, and the quality of the nurse's work life. Safe staffing must allow enough time for the RN to assess and make decisions for safe delegation, supervision, evaluation, and follow-up. We know that staff satisfaction impacts patient outcomes. Certain facilities or units may use specific nursing care delivery models. These include total patient care, functional nursing, team nursing, and primary nursing. In total patient care, the RN provides total care to the patient for the entire shift. This works best in a setting like the ICU. The functional nursing model divides care into tasks that each member then provides to a care group. So one person would pass meds, one person would do like the ADLs, the hygiene, and one person would do assessments, etc. Care can be very fragmented with this model, and no one person spends quality time with the patient. The team nursing approach assigns an RN team leader with LPN LNAs to a group of patients. The RN delegates care based on patient need. That means the RN needs to be familiar with all of the patients. This is a common practice on medical surgical inpatient units. And a modification of this is called modular nursing or pod nursing, which is common in places like the emergency department. The primary nursing care model is used in things like hospice or long-term care, where one RN is assigned to be responsible for the plan of care for the patient, and they will update and modify the plan as necessary, and the rest of the team follows the plan. The transitional care team is another example of the primary nursing model. Regardless of the leadership or management style and staffing model used, the goal should be safe and effective patient-centered care. When there is an issue with patient care, such as an omission or an error, the RN is responsible to make sure that an event report is created so the event can be reviewed. After all, it is the patient who truly defines the quality of their hospital stay. Sentinel events are events where the patient's safety is compromised and the injury reaches the patient, or the event reaches the patient, resulting in death, permanent harm, or severe temporary harm, and there is intervention that is required to sustain life. This would be things like a medical error that causes cardiac arrest, or a surgical error where something is left inside the patient, somebody who is dropped or falls on the floor, and they have a head bleed and eventually they die. A root cause analysis is a problem-solving method that helps identify how and why an event occurred. So sentinel events always have root cause analysis performed on them. And these focus on positive preventative approaches to system and process change. Kind of the thinking is, like, if it can happen now, it can happen again, so how do we prevent this from happening in the future? At our facility, we use a root cause analysis model called the 5 whys. And so you start by asking, like, why did this happen? And then, you answer that question and you ask, why did that happen? And then by the time you reach the 5th why, that tends to be the root cause of the event. No-fault reporting is critical in event reporting, and that's the theory that all events should be reported without fear of repercussion to identify systems issues rather than to avoid discipline. And so the thought is that if there's a risk that you'll get in trouble for reporting an error or an omission, that you won't report it, and then multiple people will be experiencing the same error or omission and it won't be getting reported, and there's a systems issue behind that that could be repaired or fixed, and nobody knows about it because it's not being reported. So no-fault reporting is huge. It's important. Critical and clinical pathways are roadmaps that the patient and the healthcare team should follow to guide the patient's care management and recovery. And these are discussed in terms of staffing, and then also in terms of safety and quality, and in terms of patient care, because they cover so much ground that they're very broad in their scope. But really, these define the optimal sequencing and timing of interventions by physicians, nurses, and other interprofessional team members when you're providing care for a patient with a really particular diagnosis or procedure. So there's like a CHF critical pathway, and there's like a renal failure critical pathway, and there's a heart transplant critical pathway, but it basically goes by best practice for people that really improves patient outcomes and decreases these sentinel events. They're developed through collaborative efforts to improve quality and the value of care provided. And it's important that nurses participate in both root cause analysis meetings and the creation of these critical pathways to help improve the systems where they work. Nurses should also be active in political action, policy creation, and advocacy. But be careful of the message that you send. Look at this picture. She firmly believes in the message that she is sending. Keep your politics out of my healthcare. What does that convey to you? That she knows better than the politicians? That she's unwilling to collaborate? Do you really want to keep politics out of healthcare? Medicare and Medicaid are federally funded. Healthcare reform occurs at a legislative level. The legislative branch of the government, or Congress, right, the Senate and the House, has the power to tax the people of our country and allocate that money. They determine the reimbursement rates for healthcare services. Do we really want to keep politics out of healthcare? Or do we want to have a conversation with our legislators about what healthcare needs? Political action is so important. The message that we send is critical. If your goal is a voice, to be heard, to be respected, to really be listened to, your message matters. You gain power by joining professional organizations like the ANA and your state chapter, as well as any specialty care area organizations that you represent. You gain power by joining committees at work and locally, by being part of the conversation, bringing research to the table, and collaborating with the people who also get things done. You have a voice that can be heard by making phone calls, sending letters or emails that are well crafted and not inflammatory. You have a responsibility to know and understand the issues that nurses are facing and to be a part of the solution in a proactive manner. Some nurses are unhappy in their workplace and may choose to pursue unionization. These informational sessions and meetings need to occur outside of work hours in a different location without management present. Once unionized, members pay dues and member representatives attend meetings. The union is very powerful, and they have collective bargaining power. They can help negotiate things like salaries, benefits, restrict mandatory overtime, and set limits on staffing ratios. However, if the union cannot come to an agreement with the employer, they may ask you to strike. Nurses oftentimes have a hard time walking out on caring for their patients because it violates their ethical beliefs, and it's in opposition of the professional image of nursing. So here we are at the end. You will have a choice of what type of nurse you will become. Every day is an opportunity to evaluate your current status and make a plan to change. Knowing yourself is the first step. Create that vision for who you want to become. Plan your path to success and then make it happen. I leave you with this quote from E. Hale. I am only one, but still I am one. I cannot do everything, but still I can do something. And because I cannot do everything, I will not refuse to do the something that I can do. As always, thank you for watching. Have a wonderful holiday.